Good afternoon, and thank you for joining us for today's health talk on scoliosis, what every kid and parent needs to know. A couple of housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through audio, please note the QA function on your screen. If you have a question that is not addressed in the presentation, please feel free to submit through the QA feature, and our presenter will try to address as many as possible at the end of the talk. Also today's webinar is being recorded and will be posted on our website. So as a registrant of today's session, you'll receive an email with the link once that presentation is live. And now it's my pleasure to introduce our presenter for this session. Dr. Michael Glotzbecker is Chief of the Division of Pediatric Orthopedics at UH Rainbow Babies and Children's Hospital and Clinical Associate Professor of Orthopedics at Case Western Reserve University School of Medicine. He holds the George H. Thompson Chair in Pediatric Orthopedic Surgery. And Dr. Glotzbecker specializes in treating scoliosis and all other complex spinal conditions. And now it's my pleasure to turn it over to Dr. Glotzbecker for our session today.
Great, thank you, Tia, and I appreciate everyone joining us on this very beautiful day outside. And a lot of us have gotten a little bit more familiar using this sort of Zoom format, and I think that this is a good way to get information out there and try to get some of your questions answered. Being relatively new to the area, we just moved here from Boston in the fall and now are here in Cleveland, and so now have an opportunity to sort of get to know some of you. So today we're going to talk about scoliosis, and you have to understand that there's lots of things that cause scoliosis, and we could talk at length for a very long time, but we're really going to focus on idiopathic scoliosis, which is the most common scoliosis. So this is a little bit of an outline of what we're planning on talking about today. So, if you have a diagnosis of scoliosis or a new diagnosis of scoliosis, we'll go over some of the basics. What is scoliosis? What causes it? How will it impact your life? Does it cause pain? How does it affect what you do as far as sporting activities? Then we need to talk a little bit about what the natural history is of scoliosis, because what happens as an adult really determines how we need to treat it when you're a child. And then we will go through the treatment options that exist and when you maybe use them. And then also a little bit on how you maybe can find additional information in the world of Dr. Google and all the information that's out there. So if you have scoliosis, the first thing is take a deep breath. As we'll see, scoliosis really doesn't cause symptoms, and it's really not a danger, particularly when it's small. And even when it's on the bigger side, it doesn't really cause any immediate issues. Remember, you probably didn't even know it was there. So most people who are diagnosed with scoliosis are picked up at their pediatrician's office without any symptoms at all. And if you come to a scoliosis clinic and look around the waiting room, you'll see that 15, 20, or 25 kids with scoliosis are all being seen that day. And scoliosis isn't really causing symptoms. So even though a lot of people think that scoliosis, and it makes sense, would cause back pain, there are very good studies that basically show if you have scoliosis or you don't have scoliosis, both of those populations have a baseline level of back pain, and it's really no different if you have scoliosis. The reality is 50% of 15-year-olds, 80% of 18-year-olds will have back pain at some point. 100% of us adults will have back pain at some point. So there's lots of people that have scoliosis. There's lots of people with scoliosis and back pain, but there's also lots of people that don't have scoliosis with back pain. So it really is not any different. So what is scoliosis? Well, it's a curve of your spine that goes side to side. That's how we think of it most, but it really is a three-dimensional curve. So if you look at people from the back or from the side, you'll see some other subtle changes. You'll see rotation, and that's what the pediatrician will often see. And if you see the pictures on the right, you can see how the ribs stick out more on one side than the other. It also changes posture. So most kids with scoliosis have actually very good posture, very flattened back, as opposed to a rounded back, which we call kyphosis. And so scoliosis does not mean hunchback. So a lot of people, when you ask, does someone in your family have scoliosis, they'll have a grandmother or something that has, a hunched over back. And that is usually from osteoporosis, where the bones get soft and then it tips you forward. And so if you have scoliosis, it does not mean that you're going to necessarily look like that. as you get into adulthood. So who is the typical kid with scoliosis? Well, it's your typical pre-adolescent 10, 11, 12, 14-year-old who has zero symptoms, healthy, playing sports, running around, doing everything normal. Again, as it does not cause pain, the most common direction of the curve, or where you'll see it most often, is that it heads to the right in the chest area or the left in the waist area. And that's the most common place we will see it. And again, if anything, their posture with scoliosis is actually flat, and they aren't generally rounded. The next thing you realize is this is not caused by anything that you have done as a younger child. This just happens. And the reality is idiopathic scoliosis, as I talked about, there are lots of other causes of scoliosis, but idiopathic scoliosis by definition means we don't know what causes it. So these are otherwise healthy kids with no underlying medical issues that get it. Now, certainly there are scoliosis that comes with other conditions, but again, we're not talking about that today. Does it run in families? The answer is yes, sort of. So it definitely clusters in families, but it's not a direct lineage down. So it's not like if a father has it that the child will definitely have it. Sometimes you could have a cousin that has it, but a sister that doesn't. And so it does cluster, but it doesn't necessarily tell you that you will have someone who has scoliosis. And it also doesn't help you know the severity of that scoliosis. So why did this happen? Well, it's not how you sat, so it's not bad posture. And I know that a lot of people like to blame it on that. It's not caused by backpacks, and it's not caused by what sports or activities you do. So again, this just happens. And unfortunately, we don't have a good reason, even though people, obviously, it's natural to want to know what actually caused it. So that leads us to the next one. So what can you do? Well, the good news is, because we don't really know what caused it and nothing that you're doing is causing it, you can continue to live life as you did before. You don't need to drive yourself crazy about what you're doing or not doing, because there's really nothing you can do. The problem with that is everyone wants to do something. It's very frustrating as a parent to look at your child who has a curve in their back and say, I really want to do something that can influence this in a positive way. Certainly when we get to some of the treatment options, there's things that you can do, but as far as day-to-day activities or what you're doing as far as routine does not need to change. The next thing you know about scoliosis, this does not change your ability to do anything that you like to do. So your sports career can continue to play any sport that you want. It does not affect it in any way. And so therefore, if you have a diagnosed scoliosis, you're going to be able to continue to do what you want to do. And that even is if you need treatment. It's not going to affect your performance. It's not going to make your scoliosis worse. And even if you need treatment, such as a brace or surgery, you can take the brace off for all of your sports. And even if you have surgery, I let all my kids go back to whatever sport they were playing beforehand. So even if you have a more severe curve, it really is going to allow you to continue to do the things that you like to do. The other thing I like to counsel my families and kids with scoliosis is to own the diagnosis. So especially if you're going to be treated in a brace, the kids that hide from it often struggle the most. So I like to say, don't put your head in the sand, because my best brace wearers are actually the ones who tell their friends. You know, middle school, high school, it can be a tough environment, especially with fear of what people might think. But the people that sort of are afraid to tell their friends actually struggle much more. And those that say, hey, I've got a brace, this is what I'm doing, do great. And they're often fine with it. So I want to talk a little bit about what tests you may need or what you may see if you come to the orthopedist or even your pediatrician. So, you know, as I said before, the thing that we actually see is it's really hard to see the curve side to side, but because there is this twist associated with it, you can see the ribs higher on one side than the other, or the muscles higher on one side than the other. So we use this tool that's called a scoliometer, but this approximates how much rotation you have in your trunk. And this really determines who needs an x-ray. So there's thresholds. Once you have a certain amount of rotation based on this device, that determines whether or not you need an x-ray. So if there is enough and you need an x-ray, what x-ray do you need? And there's this thing that you may hear about, a Cobb angle. So usually you have an x-ray taken from the front and also from the side. And basically, if you look at this curve, you try to find the bones that are tilted the most on either end of the curve. You then draw an angle between it, and this is how we actually quantify it. This is what determines how you may be treated. But it's important to know that there is a range of error in measurement. So I try not to get too focused on the exact degree. I often will give you a range because it can change a little bit based on how they're positioned or how you're standing. And also just between different people, we may measure it off by a degree or two. So you want to get in the ballpark so it puts you in a sort of zone as far as determining what treatments you may want. The other thing you need to do is the two things that matter for scoliosis are how big your curve is, as well as how much growing left you have. So when you come to the office, we'll often ask questions, have your period started? Have you grown a lot in the last year? These are all things that we can use to try to figure out where we think we are with regards to growth and the growth spurt. There are other things that we can do. We often can see growth plates on the hip, and that will be seen on the x-ray of your spine. And then the thing that I use the most, if I'm really trying to figure out where someone is with regards to growth, I'll actually x-ray your hand, because the growth plates have certain characteristics in the hand that change as you reach maturity. And so we can gauge how much growing you have left, not necessarily the number of inches, but the amount of time you have left by looking at a hand x-ray. The good news is there's always a fear of radiation exposure. Obviously, no one really wants their kid to have too many x-rays, but there is new technology, and this is coming to Rainbow. It's been purchased and it's being built as we speak, a new low-dose radiation x-ray machine that basically reduces the amount of radiation that you're exposed to for a typical scoliosis film by 50 to 85%. And when we're following this long-term, we can actually put it at a lower dose that has a little bit less detail. That's another 5 to 7 times less. It gives us both views, and we can actually use those images to reconstruct the spine and look at it three-dimensional, which has great value as far as surgical planning. So this is great. This will be at the Rainbow Main Center, I hope, by the end of the year. It does take some time to get there. So the next thing we need to talk about is, what happens to scoliosis as an adult, because that really determines how we're going to treat kids as they finish growing and as they reach maturity. So, what do we know about untreated curves? And in reality, what we know about untreated curves is there are actually studies of people in Iowa that are in their 60s and 70s that they followed over 40 or 50 years to see what happened to their curves as they moved from adolescence into adulthood. And the reality is, when you're still growing, any size curve can get bigger, but may not. And we're not very good at predicting. So if you come to me and you have a 5-degree curve or a 10-degree curve or a 15-degree curve or even a 25-degree curve, clearly it's gotten there in some way, but I can't tell you whether that's going to jump to 35 or 45 or 55 or it's going to stay the same. So if you're growing, that's why we need to monitor and follow it. The data is a little bit better at the end of growth. So we know if your curve is small at the end of growth, and we'll give you some numbers for this, those curves are not likely to get bigger as an adult. So you basically don't have to worry about them. But once those curves hit a certain size, those curves are likely to continue to get bigger even when you're done growing. And so those are the kids that sort of may end up in that surgical category, because we know that if you have a curve at age 15, it's going to be bigger by the time you're an adult. So which curves get bigger? So again, that Cobb angle, which is the way we quantify how big the curve is. So curves in the chest area or the thoracic spine that are bigger than 45 to 50 degrees are at risk for getting bigger. That number is a little bit less when you look at curves in the lumbar area or the waist area. And the reality is, we don't really know why these curves get worse where smaller curves don't. It probably has something to do with once it gets to a certain threshold, there's a certain amount of gravity that takes over. Unlike a curve that when you're still growing, curves can get worse relatively rapidly, meaning it could change 5 or 10 degrees in a year, and that's not that unusual. These curves that are above these thresholds when you're done growing do get worse, but they get worse slowly. So it's about an average of a degree per year. So if you're 15 years old and you have a 50-degree curve, it'll be 35 when you're, it'll be 70 degrees when you're 35 years old. So what happens if you don't treat scoliosis? Let's say you have a 25-degree curve or a 35-degree curve or even a bigger curve. What does that mean as you get to be 30, 40, 50, 60 years old? Well, the reality is they've looked at these people who have scoliosis untreated. There's no difference in lifespan. There's really no difference in flexibility. There's no difference in your ability to walk or the strength you can do. And so basically kids who become adults with scoliosis do just as well as adults who don't have scoliosis. The one caveat to this, and this is what really drives treatment, is that scoliosis above a certain size, once it gets to be about 70 to 80 degrees, can start affecting your lung function. So that means that if you're in your 30s, 40s, or 50s, and that curve has gotten that big, you may start having shortness of breath. And again, this is the main driver of how we actually treat scoliosis, or why we treat scoliosis. It's for lung function as you progress into an adult. This is the big thing that people want to talk about. And again, I mentioned it earlier, but if you actually look at people with scoliosis, and this really applies to kids, adults with big scoliosis, there really is no major difference in the amount of back pain. If you look at really big scoliosis, there is slightly more mild pain in patients with big scoliosis. And again, this is probably the second driver of why patients may end up having surgery. But if you look at people with smaller curves, there's no difference in back pain. And even the ones with big curves, although they have slightly increased amount of mild back pain, those with severe back pain is exactly the same as those without scoliosis. And there is no increased risk of being on disability or being unable to work because of that scoliosis. So those are important things to realize. And again, lots of us who are adults have back pain, and we may blame it on a curve in our back, but that's also just because we're adults and are prone to having back pain. What about how we view ourselves? Well, if you look at adults who have scoliosis, most of them are slightly dissatisfied to slightly satisfied. If you look at patients who don't have scoliosis, we're all slightly satisfied to moderate satisfied. So I think we all think that we probably could be a little bit better whether or not we have scoliosis. So the key is with scoliosis, I don't think it's significantly different between those two groups. So now what about your curve? So let's put it in a category and try to figure out how we need to treat it. So really you're going to fall into three categories. So what happens if your curve is small? And the overlay of this is whether you're growing or not. So what happens if your curve is small and you're still growing? What happens if your curve is small and you're done growing? What happens if your curve is medium and you're done growing? What happens if your curve is large and done growing? And again, if you're growing, it changes the game a little bit. So let's say you have a small curve, less than 10 to 15 degrees, or even, up to 20 degrees. That means if you are done growing, it won't get bigger and it's not going to cause pain. You will live the rest of your life with that 5 or 10 or 15 degree curve, and it will be no different than if you didn't have scoliosis at all. So your ability to do everything is no different. You're going to have no increased risk of being on disability, no different inability to work or anything like that. If you're still growing, then you need to be watched. And again, because we're bad at predicting who's going to get worse and who's not, we need to watch it. And the only way to watch that is to either come in at an interval, and it depends on how big your curve is and where you are with regards to growth. Maybe it's every 4 months, maybe it's every 5 months. And you'll either have x-rays or just a clinical exam, because we can follow the rotation over time as well to try to avoid some x-rays. So what about a medium curve? So let's say you have a 25 degree curve or a 30 degree curve or a 35 degree curve. And on this x-ray, these are both probably about 35 degrees. We're going to call you a medium or a moderate curve. So if you're still growing, you clearly need to be watched because those curves can get worse. But as you get to a more medium-sized curve, those are the kids that end up in a brace. And we're going to talk about a brace in a little bit more detail in a few slides. But this is the area that as a growing child, you may end up needing to be treated. However, if you're done growing, you have a 25 degree curve or even a 30 degree curve, those curves are unlikely to get bigger. And again, no increase in those medical issues, just as we talked about with the smaller curves. And there really is no role for treating a curve like that, because the brace doesn't correct your curve. It just keeps your curve from getting bigger as you grow. So if you come in and you're done growing, you have a 25 degree curve, there's no reason to have a brace because it can't affect it. It's not going to improve it. And because you're not growing, it's not going to get worse. There's no reason to treat it. So the only impact you'll have if you have this moderate curve is that you may see some asymmetries with regards to the ribs or your waist, but it will not affect you in a medical way at all. And then once your curve gets bigger, again, this curve is probably about 50 or 55 degrees. These are the kids that you need to start thinking about doing something. And so if your curve is large, you are likely to be completely asymptomatic. As I talked about before, it's unlikely to be affecting your lungs, not likely to cause you back pain. If you're still growing, it's likely to continue to get bigger. Even if you're done growing, it's going to get bigger, but slowly. So if you have a curve that's above this 45 or 50 degrees, or maybe a little bit less in the waist area, the concern is that curve will continue to get bigger as an adult, and it's more likely to cause either back pain or lung issues at a later date. So these are the kids that you need to have surgery. The hard part about it is that most of the kids that end up having surgery are 12 to 15 or 16-year-old kids who have no symptoms. So we are doing an operation to prevent problems as an adult. Sometimes it's really hard to understand or rationalize why you may need surgery when you're completely asymptomatic. So again, we're doing something to try to help these kids as adults, but still it's a big procedure to go through when you don't have any symptoms. And so that's part of the understanding that you have to get to when you have to make that decision. And the reality is that, so you could ask, well, why don't I wait to have surgery as an adult? Well, if you have a 50-degree curve at age 15, that's going to be 70 degrees by the time you're 35. It's a lot easier to get out of bed in the morning when you're 15 versus 35. Life is as complicated as it is as a teenager. It gets more complicated as an adult with jobs and kids of your own and things like that. So getting through the surgery is much easier with a smaller curve at a younger age, and they do better than adults. And this has been shown scientifically, but it also just makes sort of common sense. So what are some of the treatment options? So we'll go through these a little bit. So a lot of people will have questions about non-operative treatment. And so, does physical therapy help? Are there exercises that can help? So there are scoliosis specific exercises. The name for them is Schroth. They have been around for a very long time. They were very popular in Europe. And there are studies out there that show that they do potentially have benefit. The problem is a lot of those studies haven't necessarily been scientifically very rigorous, but also most of those studies have combined physical therapy plus a brace. So it's difficult to separate out the brace. That being said, doing exercises for your back has never hurt anybody. Get your back stronger, reduces your risk of back pain, and it may help with scoliosis. So if people are willing to commit to it, I think it's a reasonable thing to do. There is no evidence that chiropractic adjustments or things like that can make a difference. And the way to think about this is I can put kids in a brace, and the best I can do is keep that curve from getting worse. I can't correct it. And that's a brace that's on a kid for 16, 18, 20 hours a day where I'm pushing on the spine the entire day. So to think that maybe you can adjust it at an hour session once or two a week, I think it is pretty difficult based on the fact that I can't make it move very well with a brace that's on all day, 7 days a week. So if you need to be braced, the reality is bracing is worth it. Now, no one wants a brace. It's really hard to be put in a brace when you're in middle school or high school, but the reality is it does work. And this is probably the most scientific slide I put in this talk, but I think it's important. So if you look to the left, you can see that if you have scoliosis and you don't do anything, you will progress to surgery about 50 to 60% of the time. So that means you might get lucky 30 or 40% of the time. If you wear a brace, that gets reduced to about 30%. So the percentage there are success rates. So 70 to 75% of the time, if you wear a brace, you will avoid surgery. So it improves your percentage of avoiding surgery from 40% to about 75%. But if you actually look at the graph, and the reason I put this is I actually show my patients this, the number of hours you wear it can actually influence this further. So if you look at kids who wear the brace close to 18 hours a day, your success rate goes up to 85 to 90%. So again, you can move the needle of, needing surgery 60 to 70% of the time to down to 10% of the time by wearing a brace. So it does work. And although it socially can be difficult, it is scientifically proven to work. And this was done in a very rigorous way, this study. So who gets a brace? Well, the kids that have curves in that medium range, so 25 to 30 degrees, or a curve maybe that you've seen move. So if I have a kid who has a 15 or 16 degree curve and I see it go to 22 or 23, I'm not necessarily going to wait for that to get worse because it's already proving that it wants to misbehave. If you have a lot of growth remaining, that may lower your threshold, meaning if you're 14 or 15, I'm more likely to not put you in a brace unless that curve is closer to 30 because I know you don't have enough growth left to get that curve up to that 45 to 50 degrees. But if you come to me and you're 8 years old or 9 years old or 10 years old and you haven't hit your growth spurt, I may be more likely to put you in a brace at 20 degrees just because I know we have to get through that big growth spurt before that's coming up. And that's the time at greatest risk of progression. It's not easy. So obviously this can cause a lot of stress in the household. You'll meet people who have different philosophies on this, but if you look at that graph and the data, the more hours you wear this, the better. So most of my kids, I have in a brace about 18 hours a day. That usually means sleep and school. Sleep is easy. School is the socially hard part, but you take it off for 5 or 6 hours every afternoon. You play all the sports that you want to do. All fun things are done out of a brace. And again, it's an average. So if someday you want to go to the pool for 12 hours and then next day it's raining, you can wear it more on the rainy day and take it off for more on the nice day. And so there is some flexibility as far as that goes. And you can actually get a monitor in your brace that can tell you how many hours a day you're wearing it. And it's like a little bit of a report card and a little bit of a challenge, which some of the kids like. It does mean you get a new wardrobe, so you got to look for the positives. So, there are ways, and if you read out there, there's lots of people that can show you how to get clothes that sort of incorporate the brace and hide it. But again, even if you do that, as I said before, I think it's important to tell your friends that you're wearing a brace, because then it takes a lot of that stress away. Now, surgery. So this is the last thing we'll talk about, and then leave some time for questions. The reality is that most of us who have relatives have experience with adults who have had back surgery. And what I will tell you, that surgery on kids for scoliosis is dramatically different than that in adults. And so, if kids do need surgery, they recover very well. They're out of bed the day after surgery. You do not need a brace after surgery. You feel sort of worn out, tired, sore, sort of angry at the world for about 2 to 3 weeks, but most feel pretty good in a month. And most who do this during the school year are able to get back to school at about 3 or 4 weeks after surgery. And I've even had some sooner than that. And usually by the time I start letting them do stuff, I actually need to hold them back because they're feeling too good. So this is what surgery looks like. So you can see the x-ray and the clinical photo on the left, and then what it looks like after. It's done through a single small line up the middle of the back. We then hook these metal screws or other devices to the spine and then use the rods to straighten it. It's a good operation. So the curve is usually corrected to a large degree. It doesn't go to 0 degrees. Usually there's still 15 or 20 degrees left. But again, I don't focus on that number because the goal is to fuse the spine and keep it from getting worse as an adult. The rib prominence and the waist asymmetry get dramatically better. There are risks, but the risks are low. So about 1 in 50 risk of reoperation in the first 2 to 5 years, and the risk of a nerve injury is very low, less than 1 in 1,000. And most of these kids fly, so they're out of the hospital in 2 to 3 days, out of school for 3 to 4 weeks. I usually keep people out of non-contact sports like running, jogging, swimming, biking for about 3 months, but at that 3 months, they can do all of that. And at 6 months, you can go back and play tackle football as far as I'm concerned. So really no limitations whatsoever. The biggest issue is if you do a sport that requires a lot of flexibility and you have a fusion that goes lower into your lumbar spine, that can change that flexibility a little bit, but it does not mean that you can't go back and do it. And so adult surgery is very different. Again, just as I said before, it's easier to get out of bed in the morning as a teenager than an adult, so it's also easier to recover from surgery. It is totally different than adults who've had surgery, and it's a different diagnosis, it's a different treatment, it's a different age group, but the reality is your relatives are going to want to talk about it. So it's just hard. You just need to make sure as best as you can to separate that experience from what you will actually have. And how should you learn more? So I think this is the last question. There's a lot of information out there, and how do you navigate that to figure out and the things that you want to figure out before you make your decisions? So, ask lots of questions and write them down. I mean, the reality is you come into the doctor's office, whether it's a new diagnosis or not, you maybe get a little bit nervous, you forget what you want to ask, and then you walk out the door and say, gee, I wish I had asked him that question. So come in with a list. I think that's one of the most important things. And then, you're going to probably see me or someone else again. And so you can write those questions down so at subsequent visits, you're able to bring them up. This list is important, right? So you can write it down at any point so that you have it, because especially if it's a new diagnosis or you're talking about a brace or you're talking about surgery, these things can be upsetting and for good reason. And so you're going to think of a lot of questions after you leave. You'll forget them the next time because it may pop in your head. So just write them down. There's never a bad question. Again, these are big decisions. And then do your homework, but be careful what you read. Dr. Google doesn't always bring you in the right direction. And the question is, where do you turn? So the problem is you can get into some scientific sites, and they're maybe too detailed or too scientific. You can look at blogs, but people are more likely to post sort of negative experiences on blogs than positive experiences. So I think you can ask your doctor direct questions. Hospital websites, including Rainbows, has a lot of educational content that's very good. There are a few sites out there that are pretty good, and some of them are shown here, but Setting Scoliosis Straight, the Scoliosis Research Study, those are sites that we all advocate for and are members of, so we know that the information there is good. But again, I think ask your doctor where you should turn, because I think that this is really important. You don't want to get misinformation. And then regardless if you need follow-up or not, especially if you're making a decision about surgery or bracing, just make another appointment. You can come in and talk again and bring up a lot of those things that maybe you wish you had asked the first appointment. And then, you know, the reality is once everyone's come down, bringing those questions, it is a big decision. But again, as I just said, you know, most kids with scoliosis are going to do great as adults. Even if you need surgery, they do great and go back to all activities. So you still need to get comfortable with your decision, but, you know, it's going to be okay. You know, these kids do very well. And this diagnosis really overall is really not problematic in the long run. And so I am going to stop there so that we can answer some questions. And I think Tia will be managing them, but if you have some, just put them in the Q&A box.
Exactly, Dr. Glatzbecker. Thank you so much for that very thoughtful presentation. And I do want to remind, many people joined after we got started. So I will remind everyone, if you have a question, now is your time to ask. We have plenty of time to handle all those questions. You won't be able to do that audibly, but you can put your question in the QA function. So Dr. Glatzbecker, we have one question that asks, what are your thoughts on 2-week boot camp style scoliosis correction therapy or the traction chair? We are considering a 2-week session with a chiropractor in Miami who has seen good results with his patients.
Yeah, so it's a good question. I've had some patients that have done them. I will tell you what I know. What I know is that, you know, the best evidence out there is that a brace is the best possible treatment. And the best I can do with a brace is have someone wear 18 hours a day, and I can keep the curve from getting worse 70 to 85% of the time. Now, I will tell you that I have some kids that have no treatment that improve a little bit. I have some kids that are braced that improve about 5 to 10%. And so the problem with these boot camps is that they tend to advertise and really focus on the 5 to 10% that get better. I can't really necessarily explain or understand the 5 to 10% that get better, and I can't predict it in, you know, the type of practice that the treatments that we have. So they tend to advertise that as opposed to the other 80 or 90%. And I can tell you the kids that I've had to go to boot camp, their curves got worse and they still needed surgery. So they're often very expensive. They often have you get x-rays, and, you know, they take the x-rays in different ways that can influence how the curve looks. And so I would be cautious. I can tell you if it was my kid, I would not send them, because again, I don't think there's anything that a person could do over a day period or 2-week period or a week period that can really change it. I just think that they are focusing on that same 5 to 10% that I have in my practice that I brace, and they're just advertising that small sliver of the population. So I don't think it's a great idea, and I think it will cost you a fair bit of money to do so. And I think the results that come out of it are, again, you might get an x-ray that looks better, but I actually pinned and sort of really asked my patients that have been there, and they clearly took the x-rays differently. So if you take an x-ray lying down versus sitting versus standing, those all will influence your curve. It doesn't mean your curve is actually materially changed. So I would be cautious.
Great. Second question, what kind of brace do you typically recommend? Boston, Providence, Rigo?
So that's another excellent question. And I generally prescribe a Boston brace, and that's not because I'm from Boston, but the most common brace used across the country is a Boston brace. There's different types of braces. There's full-time brace styles, and then there's nighttime brace styles. So the full-time brace styles are either the Boston brace or the Rigo Cheneau brace. The Rigo Cheneau brace, the philosophy behind it is there's a little bit more rotational correction, but the Boston brace now is a Boston 3D brace that does the same thing. So I think either a Rigo Cheneau or a Boston brace are the two most commonly used full-time braces. And I really believe in full-time bracing based on that graph, that the number of hours you wear it improves your outcomes. A Providence brace, and the other main one is a Charleston nighttime brace. Those are nighttime braces. I know that they are used a lot in Cleveland because a lot of people here have patients in nighttime bracing. The theory behind those braces is that they're a little bit more asymmetric, so they're really hard to wear during the day, but they try to overcorrect the curve at night so that they then maybe you have to wear it a little bit less. What I can tell you is it might work, but there really is no science that has compared those night braces to a full-time brace very well. And so I'm not a huge advocate of it, even though it's the nice thing to do. Many patients would like to be in a nighttime brace, so they look for that answer. But the problem is it's hard for me to argue against the information that the more hours you wear it, the better you are. And so that's why I just have trouble doing a nighttime brace. And that's, that was pretty standard at many places, but you certainly will find some people that use nighttime braces for sure. It's just a little bit different philosophy.
Great. And then another question, what do you think of VBT surgery?
Yeah, so vertebral, so for those you don't know, VBT surgery stands for vertebral body tethering. And what I talked about today is the most common procedure for a scoliosis is called a posterior spine fusion. So you basically put the screws and rods in the curved part of the spine, you straighten it, and you get the bone to fuse together so that it does not get worse as an adult. Vertebral body tethering is done differently. So it's done through small incisions, and you usually go through the chest, and you attach the implants to the front of the spine instead of the back of the spine. And what you actually do is you attach them only on one side of the curve. So you put them on one side of the curve to allow the other side of the curve to grow. And so you have two advantages. One, it's a flexible tether, so it's potentially a little bit more flexible than a fusion. And number two, you actually will get correction over time because you will harness the growth. So there are advantages. It just recently got approved by the FDA. I am certified to do it. So I've been through you have to go through special training and stuff to do it. So we can do it at Rainbow. But the window of opportunity is relatively small. So you need a curve of a certain size. That curve needs to be flexible, and you need to have the right amount of growth left. Because if you do it too early or have too much growth left, then you'll overcorrect and have trouble. And if you do it too late, you won't have enough growth to correct. So the problem with some of the people that have done tethering across the country early is that the indications for when they did it, I don't think were perfect. I think there is a small window for which it's very appropriate. And so I definitely think some patients are going to benefit from it, and we can do that. But you have to fall in that window to make sure that it's the right operation to minimize the risk of needing additional surgeries or having additional complications.
Okay, this one's very specific. My daughter is already at about RISER 3 and 12 years old. I do not even know if that is an option. My daughter is already in a Rigo Cheneau 20 hours plus. So that may be connected to the body tethering question.
Yeah. So so the RISER sign, as I talked about, that's just for those who don't know. So RISER sign is looking at the growth plate on the pelvis on the x-ray, and the cartilage turns to bone in a specific way. When you still have not hit your growth spurt, you're considered to be RISER 0, and that means it's all cartilage, no bone. And as that bone ossifies, you go from RISER 0 to RISER 5. And so a RISER 3 means that you're probably through the biggest growth spurt and your growth is slowing down. So it may be that you're past the window where it would make a big difference. But we usually take a hand x-ray to get a more exact thought of where you are with regards to growth, because that's a more accurate way to sort of put you in a position of knowing where you are. So, a RISER 3 might be too late. In which case I'd say you just continue the brace, but the hand x-ray would probably determine in a better way where you fit as far as on your growth curve.
Okay. All right. Can swimming or yoga improve a curve?
So another good and common question. So swimming and yoga are probably good for back in general, meaning strengthens your back, reduces your risk of back pain. Again, there's not any data to say that any specific activity makes it better or worse. So I don't advise people I say if you want to go swimming, but I can't say that it's necessarily going to change your curve. And that's, again, same sort of philosophy. Again, if a brace is on 18 hours a day and keeps it from getting worse, it's hard to imagine certain activities are going to be able to move the needle or influence it that much. So I don't direct kids into certain activities or or not to do certain activities, I let them continue to do whatever they like to do. So if your kid likes to swim, then I say, okay, and I can't tell you it's going to help the curve, but it's certainly not going to hurt with regards to back pain and posture. But if someone doesn't like to swim, I never tell them, hey, you should start swimming because it's a good activity for your back. So, but those things are good in general. So it's not, activity in general is good, but I don't necessarily think it will influence the curve.
Okay. What is the likelihood of arthritis at the fusion or in general with the rods? Any pointers to help prevent arthritis?
Yeah, so that's a very good question. And to be honest with you, that's the thing that we have to think about the most. So if you don't treat a big curve and that curve gets bigger, that will increase the risk that those curved bones will get arthritis and have pain just because the forces on them are abnormal. The flip side is if you have a fusion, let's say you have a fusion of your thoracic spine or even thoracic and part of your lumbar spine, before all of the bones in your spine shared the work. But now, because you fused 8 of them or 10 of them, the remaining bones have to do more work. So there's some risk that the bones below the fusion will become arthritic. There's nothing that ever says your risk of arthritis is higher one way or the other. And certainly we know that curves that are big that get worse can give lung issues. So that's why we say you should have surgery. And the other thing to know is when you correct, most people have 2 curves. So you have a thoracic curve and a lumbar curve. So even if you just fuse the thoracic and correct that, the lumbar spine often self-corrects because it's there in response to the main thoracic curve being there. The people I worry the most about arthritis who've had a fusion are people that need fusions low into their spine. So the closer you get to the bottom of the spine, probably the more stress is put on the remaining discs or segments. But sometimes it's unavoidable. And again, in those kids, most of those kids have a big curve in their lumbar area anyways that's at risk for arthritis in the long term. So we weigh those things, and I tend to try to do, and this is true of all of us, we try to fuse as little of the spine as we have to keep as many motion segments available as possible. But we fuse as many as we need to, knowing that we have to get the, correct or get the curves that are there under control.
Gotcha. Okay, this question is from a participant who had surgery back in the late 80s, have C-curve. The lower back now curves below the fusion. I've been told it is to counterbalance the upper curve. Any advice to give for this? How can one prevent it from getting worse? And should surgery be a consideration?
So it's a little difficult to know without looking at the x-rays, but the reality is every case is a little bit different. So the decision making around what curve to fuse, it's not uncommon that I will, if the curve is small enough, that I'll only fuse the chest area and leave a curve intentionally behind in the waist area because I think it's small enough that it's not going to be a problem. And I rather preserve that motion. So there are certain people who you don't get it right. If you don't get the levels right, that you can have what we call adding on, or the curve can misbehave. There's certain kids that you may fuse when they're still growing, which happens all the time. But if they're still growing, the other curve may misbehave and get worse. So there's so many factors to try to figure out what it is. And then you have this whole other adult onset scoliosis that is driven completely by arthritis, which makes it harder. So, and also the technology of fusing the spines has gotten much, much better today than it was in the 80s. And so a lot of the people who had fusions in the 80s are having some issues now based on how they corrected it. And we believe we're doing a better job of that. So every case is a little bit different. And just because there's a curve there doesn't necessarily mean it's a problem. Some residual curve is okay. Because remember, if you have a 15-degree curve or 20-degree curve or 25-degree curve and you haven't had surgery, you're no different than someone who doesn't have scoliosis in the long run. So just because you have a small curve below your fusion doesn't necessarily mean it's going to be a problem.
Okay. This is a question, I'm not sure how it relates, but will back pain get worse over the years? Well, again, scoliosis is not necessarily known to cause back pain.
So people who've had a fusion or brace aren't necessarily at any increased risk of having back pain in the long run. Back pain in general gets worse in the long run because we get older and we start getting arthritis. And as we get older, our backs are just more likely to be problematic. So whether you've had a fusion or been treated in brace or just have scoliosis in general, I would tell you the same thing, that you should strengthen your back, keep your back strong, work on your posture to keep you out of back pain. But I don't think that because you had scoliosis or a scoliosis that needed treatment, that you are doomed to a life of back pain. You'll just have back pain because you're an adult like me and everyone else.
Okay. Another follow-up from the case that we discussed earlier. The participant was clarifying that the child is at a 42-46 and the growth is over. I don't know if that impacts what you would suggest for them.
Well, it depends. It depends a little bit. So if the curve is 42 or 46 degrees and they're done growing, that's if the question is related to tethering.
Yes.
The growth being done means that tether is probably not an option. But they're in a brace, and I brace lots of bigger curves. If you look at the data, the data is for bracing curves between 20 and 40 degrees, but I've braced curves bigger than that. And it's not a line in the sand. It's not like your curve, if it's 45 degrees, is necessarily going to get worse. It just increases your risk, and many of them will get worse. So I have some of these curves in the in-between range that are in this 40 to 45 range that I just watch. And it depends on their age a little bit, but I sort of view a window of taking care of it. You could always take care of it when they're older, but from a ease standpoint, I sort of look through high school or even college when you still have summers off, that's your window to potentially take care of it if those curves misbehave. So once they're done growing, we stop the brace. If they're in that in-between gray zone, I still continue to follow them just to see what's going to happen, because I'd rather find out at age 15 or 18 or even 20 that curve is going to get worse than finding out when they're 35.
Great. And just one last question, Dr. Glotzbecker. If any of our participants today had scoliosis themselves that was corrected as a child and now have children of their own, would there be any advice that you would give them to help them, be careful about their kids and have them screened properly? What would you recommend?
Yeah, when it runs in families, I tend to be a little bit more vigilant as far as screening, meaning if I know one kid has it and they have a younger sibling, I'm like, you should probably bring them along to the appointment at some point so we can take a look. I think the advice I would give is be a little bit more vigilant in screening. You might pull the trigger slightly earlier for treatment, meaning you might start a brace a little bit on the earlier side just because you sort of know. But that being said, what your curve is does not necessarily mean your child's curve will act the same. So I would try as best you can to separate whatever experience you had to what they may have, because the curve may act completely differently and the treatment we have now is totally different than it was then. And so I would try hard, although it's nearly impossible, as you can imagine, to project those concerns or worries, or maybe even the struggles that you may be having now, which does not mean that they're going to have those same struggles.
Great. Okay, so that ends that was our last question. I'm going to just share again with our audience. First of all, I'd like to thank you, Dr. Glotzbecker, for your time today and sharing this really valuable information and answering the great questions from our audience. And then I'd like to thank our audience for their attention today in listening to this special health talk. A couple of reminders for our participants today. You will receive a link to view the session on our website once that recording is posted. So stay tuned for that. It'll come via email. And if you are interested in scheduling an appointment with the University Hospital's Rainbow Babies and Children's Pediatric Orthopedics Specialist, you can call 216-350-3206. And with that, I thank you all, and that concludes our session today. We hope you have a really great day and enjoy our wonderful weather that we're getting today.